Good morning, consultants, senior registrars, ladies and gentlemen. My name is Dr. Chioma N. Ezenyimulu, a registrar in Family Medicine Department, Garki Hospital, Abuja. Today, I'm going to do a presentation on vaginal discharge and its management. By way of introduction, vaginal discharge is a common presenting complaint among women attending general practitioner, sexual health, and gynecology clinics. Management involves good understanding of normal physiological discharge and the causes for abnormal discharge. Around 90% of vaginitis are caused by infections, mainly bacteria, vaginosis, vulvovaginal candidiasis, and trichomoniasis. Less common causes include vaginal atrophy, which is atrophic vaginitis, cervicitis, foreign body, irritants and allergens, and several rarer entities, including some systemic medical disorders like diabetes and PID, normal and abnormal vaginal discharge. Normal vaginal discharge, which is physiological vaginal discharge, is a white or clear, non-offensive discharge that can vary over time. It is thick and sticky for most of the menstrual cycle, but becomes clearer, wetter, and stretchy for a short period around the time of ovulation. Abnormal vaginal discharge causes bacterial vaginosis BV, vulvovaginal candidiasis VVC, sexually transmitted infections like Trichomonas vaginalis TB, chlamydia, gonorrhea, foreign body, retained tampons, irritants like perfumes, deodorants, atrophic vaginitis, fistulae, tumors of vagina, vulva, cervix, and endometrium, trauma like recent perineal repair or vaginal surgery from granulation tissue. Epidemiology. Studies indicate a high overall prevalence of abnormal vaginal discharge, with some studies reporting rates as high as 55.6%. The prevalence of abnormal vaginal discharge is significantly higher among pregnant women, with some studies showing rates as high as 73.3%. Urban residents, post-secondary education, being sexually active, and having no child are associated with an increased risk of abnormal vaginal discharge. Douching, contraceptive use, and antibiotic use can also be a risk factor for vaginal candidiasis in particular. Most common cause of pathological vaginal discharge in Nigeria patients include bacterial vaginosis, vulvovaginal candidiasis, and trichomonas vaginalis. These three diagnoses should be excluded in all patients before considering other less common causes like chlamydia, gonorrhea, irritants, tumors, or trauma. History and physical examination. Site and onset, where the discharge is coming from and when it started. Character of discharge, volume, color, smell, blood. Radiation, discharge is from vagina. Any urethral discharge or anal or oral discharge. Associated symptoms, any itch, rashes, ulcer, dysuria. Timing of discharge. Is it worse in the morning or at night? severity of discharge, age of menarche and last menstrual period, recent sexual history, number of partners, any symptoms of STI in partners, type of sex, is it vaginal, anal, oral, unprotected, history of any recent sexual assault, sexual history in younger or minor patients, ask for age of sexual partner, also for legal reasons, contraceptive history, blood-borne virus screen, like paid for sex, tattoos, intravenous drug usage, has had hepatitis B and C vaccine, tested for HIV, obstetric history, past medical history, past genital infections, family history if relevant, social history, smoking history, alcohol, the home environment, job, what type of work does she do, relationship, feels because of recent sexual history. You have to know about her relationships. Feelings, fears, anxieties, concerns about her vaginal discharge. As family physicians, we always talk about FIFE. I for ideas. What are the patient's understanding of the causes of her illness? Example, vaginal discharge. Function. How is the vaginal discharge affecting patient's daily life? Expectations. What does the patient want from us? That is treatment, therapy, etc. So this is FIFE. Feelings, ideas, function, expectation. EcoMap may be important in drawing and establishing problems with relationships. Example, may have a bad relationship with a relative because of sexual molestation, may feel that she does not get enough support from home, therefore seeks solace outside. Family APGA may help expose issues in family relationships. Poor APGA score may show issues with familiar relationships. Varieties of infective vaginal discharge and their treatment. Bacterial vaginosis, BV. Bacterial vaginosis is the commonest cause of abnormal vaginal discharge in women of childbearing age. Prevalence varies between 5 and 50%, with nearly half being asymptomatic. BV is attributed to imbalance in vaginal ecology with anaerobic and facultative anaerobic bacteria dominating the vaginal flora instead of lactobacilli. Bacteria commonly attributed to BV include Gardnerella vaginalis, Prevotella species, Mycoplasma hominis, Mobilinco species, etc. Risk factors for BV include vaginal douching, receptive oral intercourse, black race, recent change of sex partner, smoking, presence of an STI, example, chlamydia or herpes. This condition had been previously called Haemophilus vaginalis, vaginitis, non-specific vaginitis, and G. vaginalis vaginitis. Symptoms and signs of BV. Women usually present with a malodorous, profuse, thin, homogeneous yellow, white, or gray vaginal discharge. Typically, the patient may complain of a fishy odor during or shortly after coitus and also during menses, not associated with soreness, itching, or irritation, and nearly half of patients with BV have no symptoms. On examination, the discharge can be seen through the walls of the vagina and vestibule. Diagnosis of BV. Using the AMCEL's criteria, at least three of the four following criteria are present for the diagnosis to be confirmed. Thin white homogeneous discharge, clue cells on microscopy of wet mouth, pH of vaginal fluid is greater than 4.5, release of a fishy odor on adding alkali, 10% KOH, also known as whiff test. Note, culture is the least accurate in making a diagnosis of BV, as there is overgrowth of many vaginal organisms in this condition. Though virtually all patients with BV have G. vaginalis associated on culture, it must also be noted that the organism can also be cultured in 40 to 50% of women with normal flora. Treatment of bacterial vaginosis, recommended regimens. Metronidazole, 400 milligram oral tablet 3 times daily for 5 to 7 days, or metronidazole 2 grams single oral dose as an alternative if adherence to treatment is an issue. Topical treatment is available for women who prefer this mode or who cannot tolerate oral metronidazole. 1. Intravaginal metronidazole gel, 0.75%, 1 applicator full, 5 grams once daily for 5 days. Also, intravaginal clindamycin cream, 2%, 1 applicator full, 5 grams once daily for 7 days. Note, patients should be counseled against vaginal douching, use of shower gel, and use of antiseptic agents or shampoo in the bath. Treatment is indicated for symptomatic women and women undergoing some surgical procedures like termination of pregnancy. 2. Alternative regimens. Tinidazole 2 grams single dose, clindamycin 300 milligram twice daily for 7 days. Alcohol should be avoided during and up to 24 hours after oral and topical metronidazole treatment because of the possibility of a disulfiram-like reaction. Clindamycin cream can weaken condoms and diaphragms, which should not be used during and up to 5 days after such treatment. Note, pseudomembranous colitis has been reported with both oral and vaginal clindamycin cream treatment. Non-antibiotic based treatment with probiotic lactobacilli or lactic acid preparations are not currently recommended for treatment. A test of cure is not required if symptoms resolve. Partners do not need to be screened routinely. We move on to vulvovaginal candidiasis, VVC. This is a common cause of vaginal discharge worldwide. It is estimated that approximately 75% of women will experience an episode of VVC. It is symptomatic inflammation of the vagina and or vulva caused by a superficial fungal infection. Candidiasis is caused by the fungus Candida species, which include Candida albicans, Candida tropicalis, Candida pseudotropicans, Candida kruse, etc. Other strains are Torulopsis, glabrata, and Rhodotromla. Candida albicans accounts for 60 to 80% of vaginal fungal infection. C. glabrata accounts for 20% and C. tropicalis accounts for 6 to 23%. About 10 to 20% of women during reproductive years may be colonized with candida, but do not have any clinical symptoms or signs. These women do not require any treatment. Risk factors for VVC. 1. Hyperestrogenic state, pregnancy, hormone replacement therapy, and possibly the use of COCPs. Immunocompromised state, example HIV, cytotoxic drugs, steroids, chronic illness, poorly controlled diabetes, treatment with broad spectrum antibiotics. Contraceptive methods may play a part in the development and reoccurrence of VVC. Use of spermicidal gels and creams increases susceptibility to infection by altering the vaginal flora and increasing the adhesion of Candida organisms. Heat and moisture favors the growth of Candida species. VVC can be sexually transmitted, and several studies reported association between candidiasis and oral genital sex. Whitish, thick, cuddy, cottage cheese-like in appearance, and non-odorous vaginal discharge is usually present. Vulvar itching, soreness and irritation, superficial dyspareunia, and dysuria are other main symptoms. On physical examination, erythema, usually localized to vagina and vulva, but may extend to perineum. Edema of the labia majora and minora, and rashes on the perineum and thighs. Excoriation of fissures and satellite lesions may be seen. Diagnosis of VVC. Diagnosis usually made from history and examination. Investigations are not routinely recommended if history suggests acute uncomplicated VVC. Investigations may be considered based on clinical features and judgment to confirm diagnosis and or to exclude alternate diagnosis. Investigations, vaginal swab for pH testing if possible. If it's due to Candida, pH less than or equal to 4.5. Bacterial vaginosis and Trichomonas vaginalis, pH above 4.5. HVS for gram stain and or wet film microscopy for supporting the diagnosis when this is uncertain, such as when symptoms, signs, and or vaginal pH are inconsistent with diagnosis. Positive in 30 to 50% of patients with VVC. Culture is not indicated in acute VVC, but speciated fungal culture and antifungal sensitivity testing is indicated in recurrent VVC and with poor response to treatment. Midstream urine sample if a UTI is suspected, HbA1c test to exclude diabetes, mellitus in severe or recurrent infection, especially in prepubertal girls and postmenopausal women who rarely have vulvovaginal candidiasis without underlying risk factors. Treatment of VVC. General advice must be given to avoid tight-fitting synthetic nylon clothing and local irritants such as daily panty liners or perfume products. Vulval emollients may be used as soap substitute, moisturizer, or barrier cream. All topical and oral azole therapies give clinical and mycological cure rates of 80% in uncomplicated acute VVC. So choice is a matter of personal preference, availability, and affordability. Topical azole therapies can use vulvovaginal irritation, and this can cause vulvovaginal irritation, and this should be considered if symptoms persist or worsen. Oral therapy includes fluconazole capsule, 150 milligrams start, or itraconazole capsule, 200 milligrams BD for 1 day. Iconazole, fentoconazole, miconazole, damage latex condoms and diaphragms. Avoid co-administration of medicinal products known to prolong QT interval and metabolize via cytochrome P450, such as erythromycin, quinidine, astemizole, cisapride, pimozide, and fluconazole. If there are vulval symptoms, consider prescribing a topical imidazole in addition to oral or intravaginal antifungal such as clotrimazole 1% cream or ketoconazole 2% cream applied 1 to 2 times a day. Severe VVC, fluconazole 150 milligram oral on day 1 and day 4. This improves symptomatic relief, though not subsequent reoccurrence. Alternate vaginal therapy if oral treatment is contraindicated, clotrimazole 500 milligram pessary on day 1 and day 4, or miconazole vaginal capsule 1,200 milligram on day 1 and day 4. Some experts also use low-potency corticosteroids in conjunction with antifungals to improve symptomatic relief. Treatment of non-albicans VVC. Non-albicans species of VVC, majority are C. glabrata and are still susceptible to available azoles, though may need longer treatment course, usually 2 weeks is suggested. C. cruzae is resistant to fluconazole. Nystatin pessaries are the usual first-line treatment for non-albicans species, given at 100,000 units intravaginally at night for 12 to 14 consecutive nights. Alternative treatment options include amphotericin B, vaginal suppositories, 50 milligram daily for 14 days, boric acid vaginal suppository, 600 milligram daily for 2 weeks, dose reduced to 300 milligram daily if mucosal irritation occurs, limited evidence for boric acid and may be teratogenic, flucytosine 5 milligram vaginal cream, or 1 gram vaginal pessary daily for 2 weeks, together with amphotericin B or nystatin. We move on to Trichomonas vaginalis, TV. Trichomonas is a sexually transmitted infection caused by a flagellated protozoa called Trichomonas vaginalis. In women, the organism is found in vaginal, urethra, and paraurethral glands. In adults, transmission is almost exclusively through sexual intercourse. Vertical transmission can occur from an infected mother to her baby during vaginal delivery. Clinical features. Most individuals with TB, 10 to 50% are asymptomatic. Common symptoms include vaginal discharge, malodorous, frothy, and profuse, thin, creamy, or slightly greenish gray, vulval itching, dysuria, but these are not specific for TB. Occasionally, the presenting complaint is of low abdominal discomfort, dyspareunia, postcoital bleeding, or vulval ulceration. Diagnosis. HVS taken from the posterior fornix at the time of speculum examination. Self-administered vaginal swabs are likely to give equivalent results. Microscopy. Detection of motile trichomonas by light field microscopy via wet mouth. Microscopy is a diagnostic aid for TB and has the advantage as it can be performed near to the patient and in a clinical setting. The sensitivity is highest in women presenting with vaginal symptoms. Culture. Culture has a higher sensitivity to microscopy in identifying TB, but has now been superseded by NAAT, nucleic acid amplification test. Molecular detection. NAATs offer the highest sensitivity for the detection of TB. They could be the test of choice where resources allow and are becoming the current gold standard. On examination, the classical frothy yellowish green discharge occurs in 20 to 50% of women. Up to 70% have discharge varying in consistency from thin and scanty to profuse and thick. Approximately 2% of patients will have strawberry cervix appearance to the naked eye. 5 to 15% of women will have no abnormalities on examination. Note, sexual partners should be treated simultaneously. Patients should be advised to avoid sexual intercourse for at least 1 week and until they and their partners have completed treatment and follow-up. Screening for coexistent sexually transmitted infections should be undertaken. Treatment, systemic antibiotic therapy, is required to effect permanent cure due to high frequency of reinfection of the urethra. Treatment of TB. Regimens include metronidazole 2 gram orally in a single dose or metronidazole 400 to 500 milligram twice daily for 5 to 7 days. Alternative regimen is tinidazole 2 gram orally in a single dose. This treatment results in parasitological cure in greater than 90% of patients. Intravaginal treatment offers parasitological cure rates around 50%, which is unacceptably low and therefore not recommended. Chlamydia and gonorrhea. Chlamydia and gonorrhea can both cause vaginal discharge and a major cause of morbidity among women in developing countries. These two conditions are prevalent worldwide, particularly in Africa. They are a major cause of acute pelvic inflammatory disease, infertility, and adverse pregnancy outcomes. According to the WHO, globally, new cases of C. trachomatis infection have been estimated in 92 million, including 10 million in sub-Saharan Africa. Chlamydia is characteristically asymptomatic. About 1/3 of patients may have symptoms, including mucopurulent vaginal discharge and adnexal tenderness. The role of chlamydia in infertility is well documented. Tubal pathology in chlamydia infection is the cause of infertility in 10 to 30% of couples in developed countries and in up to 85% in developing countries. And the main cause of tubal pathology is PID. Investigations, chlamydia culture. This is considered as a gold standard because it has near 100% specificity, because only viable infections, chlamydial elementary bodies, are detected by culture. This is the method of choice for medico-legal issues. The disadvantages of culture include its low sensitivity and is that it depends on laboratory interpersonal experience. Non-culture methods include enzyme immunoassay, treatment of chlamydia infection. In the management of chlamydia infection, both the patient and her infected sexual partner must be treated. It is therefore important to screen the sexual partners and treat those who are infected. With the advent of single-dose therapy, patients are now diagnosed and treated with the highest convenience and reliability. Antimicrobial groups effective against C. trachomatis include tetracyclines, macrolides, quinolones. Gonorrhea. Most women with gonorrhea are asymptomatic. Symptoms may include vaginal discharge, urinary frequency or dysuria, and rectal discomfort. There may be lower abdominal pain, adnexal tenderness, and cervical excitation. The vulva, vagina, cervix, and urethra may be inflamed and may itch or burn. Specimens of discharge from the cervix, urethra, and anus should be taken for culture from the symptomatic patients. Diagnosis of gonorrhea. Culture. Gram-negative diplococci that are oxidase positive and obtained from selective media, thiamatine or transgro, usually signify N-gonorrhea. Carbohydrate fermentation tests may be performed, but in addition to being time-consuming and expensive, they occasionally yield other species of Neisseria. Therefore, cultures are reported as presumptive for N-gonorrhea. Treatment of gonorrhea. Any patient with gonorrhea must be suspected of having other STDs and managed accordingly. Treatment should cover N gonorrhea, C trachomatis, and incubating syphilis. Dual therapy has contributed greatly to the declining prevalence of chlamydia infection. Therefore, if chlamydia infection is not ruled out in non-pregnant women, it should be added to ceftriaxone. Role of the family physician. Like we said, we have the FIFE that we must always use in clerking the patients. As a family physician, you must know about the fears, the ideas, the function, and the expectation of the patient. So this brings us to the end of this presentation, and these are my references. Thank you.